Okay, so I just wanted to give a couple of backdrop comments. So first of all, thanks everybody for coming. Thank you to our vendors. This is primarily HIMSS Health IT organization that's global, and so we really focus on, how can we bring care to those that need it. In this particular conference, we're going to be talking with my esteemed colleague John Baackes, who's heading up as the CEO the largest public hospital. The largest public health plan in the country. So it's a pretty big job. And so what he thinks, it's kind of like E.F. Hutton, we're all going to be listening. So I've got some questions here. I'm kind of new to the public space. I'm on the other side of the fence, so to speak. I'm with the Department of Health Services, so that's where we have really 4 large hospitals, about 1,900 beds throughout LA County and a number of clinics. We also provide the EHR and health service to the Department of Mental Health and to the 2,000 inmates that are in the jail system, to DCSF and to public health. I worked in the state government in the state of Hawaii for a few years, so I had some knowledge, but I think just LA County is just really big and huge. So you got a big job, John, and so anyway, I thought we'd just start out with knowing that we're going to probably talk a little bit about the payer side today, which might be good. Oftentimes at these conferences, we kind of focus on the provider side, but so I'm really interested to hear more. And then as I'm learning, it's been 5 months I've been in the county, just how the county, how we get our money, and it's a little bit different than the private sector, but it's still the same people we're trying to reach. So John, maybe could you just share a little bit about kind of your role? I know we gave some general intros, but kind of what's it like being the CEO of the largest public health plan? And are there any areas just in general of focus? We're going to talk about health disparities, and we'll get into the weeds of that. But just kind of what's top of mind, and so kind of what are you doing nowadays?
Oh, not much. Well, first of all, it's an honor to be the CEO of LA Care. We are the largest public health plan in the United States. And I think California is the only state that has public health plans. And this was a result of the state of California anticipating moving the Medicaid or Medi-Cal population into managed care in the 90s. And there was a concern that the commercial health plans would be fickle about the rates, and if they didn't like the rates one year, they say, sorry, we're done. So they allowed the counties, if they wished to, because they were chipping in for Medi-Cal, to create public entities. So we're a separate non-for-profit entity, but we operate under the Brown rules here in California. So we are totally transparent. All of our meetings, board meetings, are open to the public, and they're quite entertaining if you'd like to come down and listen to some of the public comments. But the point of the public health plans was that because we didn't have shareholders, we could weather the ups and downs of Medicaid funding, which, as you know, is dependent on both federal and state money. Now, the feds can write debt and can keep up their end of it, but the state has to balance their budget every year, so when there's a recession, the state cuts back. And 10 years ago, or 11 years ago, when the Great Recession hit, California responded and made cuts in the Medi-Cal program. And we're just now, 10 years later, restoring some of those cuts on vision benefits and dental. So the reason I'm telling you all that is that we have weathered all of that, and we're still in business. We take care of 2.2 million people here in Los Angeles County, which, if you do the math, every 5th person in Los Angeles County is a member of our health plan, which people say, oh, that's great, John, you've got a lot of people. But the discouraging thing is 96% of our members are on Medi-Cal. And to qualify for Medi-Cal in California, you cannot earn more than $16,400 a year as an individual, or $33,900 as a family of 4. And 1/3 of our fellow citizens in this state are on Medi-Cal and living under those conditions. So by and large, we take care of people who are living and working in poverty. And in addition, we have People who are in Covered California, which is the individual market exchange that was set up by the Affordable Care Act. We're the only one of the public plans that participates in that. So if I can put in a plug, we're also now the only public option in the United States, which if any of you were following the development of the Affordable Care Act back in 2010, the idea was to have a public option everywhere, which would be an organization like LA Care that would participate in the individual market exchanges as a public entity competing with commercial plans. And that's what we do here in LA County. We compete against 5 commercial plans, and we're now the lowest price point, and we have the largest membership in the county. And that's, to me, a demonstration that the public option could work. If we can do it in a county of 10 million people, which is bigger than 43 states, we should give it a try elsewhere. So that's my little political plug. In addition, we also take care of 50,000 in-home support service workers who are all organized under SEIU. These people are generally family members caring for somebody who is frail and has difficulties with activities of daily living. So we feel that, and what I feel my biggest job is to be an advocate for those people, because they're at the bottom of the pile when it comes to handing things out. And we want to make sure that when they have an LA Care card in their wallet, they're treated like everybody else when it comes to health care. So, and
Thanks,
I'm
John.
also an advocate for the providers, and I do want to say that DHS is a huge provider for us. They take care of 250,000 of our lives, have a primary care physician who is at one of the DHS clinics around the county.
All right, thanks, John. Kind of going slightly off script here, would you be comfortable sharing, because I'm actually interested in learning how you get funding on the health plan side. Let me just give a quick little backdrop. The DHS belongs to the California Public Hospital Association, and so I just recently went to a 3-day finance class on how we, get our revenue, and it's really different than the private industry, and because we know with the, we're responsible for those that don't have the ability to pay those vulnerable populations, and for instance, Medicaid only pays 50 cents on the dollar, so we're self-funded for that other 50 cents. So where are we going to get those funds? So I know that on the provider side, we're doing a bunch of programs and things, but I'm sure is it the same with you, and kind of how do you balance the books, and where are your revenues coming from, and then we can get into health disparities a little bit more.
Well, we send a lot of money to you.
Well, thank you.
For the 250,000 people who come to a primary care doctor at DHS, DHS gets a monthly capitation amount from us, which covers all the services that DHS will render to them, including hospitalization. So it is really an approach towards population management, because we're saying for the people signed up, you're responsible for it. It's so many dollars per person per month, regardless of the number of services used, which is how we deal with all of our providers. Our funds come from the state of California, Department of Healthcare Services, and we have a contract. And based on the category of Medi-Cal that the person who enrolls falls into determines the amount of money. So it's risk-based, based on the demographics. Children we get less money for because they generally have lower costs. We get more money for adults. With the expansion that came under the Affordable Care Act, which brought in childless adults, we got a higher amount because there was a higher risk score attached to them. And for people who are in nursing homes on Medi-Cal, we get a higher amount for those. So we get a risk-based capitated amount from the state. A certain portion of that is funded by the federal government, and the total budget for Medi-Cal in California is about $105 billion a year, of which the federal government contributes $63 billion. The state makes up the rest. So we get that money in a monthly capitation rate, and we're financially at risk to cover all the Medi-Cal services those people are entitled to, including hospitalization, nursing home care, prescription drugs, you name it. Our total revenue is about $7.5 billion a year. We do, if we make a 2% margin, we're considered okay, which is one of the reasons we are competitive in the covered California space against commercial plans, which I don't think can survive on margins of quite that level. So we get our income on the basis of the risk of the people we're serving. It comes from the state. They wash their hands once they write us the check, and then we're responsible after that. And we, in turn, use a capitation payment for DHS and other providers like that, and then they're responsible to manage the care for that amount of money they receive.
All right, thanks, John. Okay, so let's get into our conference topic, maybe specifically on health disparities. Did you want to kind of share your views of health disparities and healthcare disparities, and then are they relevant today? How are we doing? Just a few words on setting the theme for our conference today. We have a couple of other panels and speakers that will be talking about interoperability and how is that helping health disparities, and I'm sure we'll talk about social determinants of health a lot, but did you want to just kind of lay the framework of why is this topic important? Why is it, there's a lot of buzz, if you're reading some of the articles and journals, any thoughts on that?
Yeah, so I think when we talk about health disparities, which are conditions that people live with that are based on their socioeconomic position in life, we're also talking about social determinants. The social determinants will be a predictor of your health disparities. So I think social determinants is a polite way of describing barriers to care for people who live and work in poverty. And let's not sugarcoat it, because I think there's social determinants when you apply to the Bel Air Country Club for membership, but we're talking about a little different set of circumstances here. So we are very concerned about identifying the social determinants that define our members on an individual basis, because they're different from one person to the next. And we know that health disparities and social determinants are going to be a predictor of the amount of money it's going to cost to provide care to you as an individual. And what we think has been missing all these years is an integration of social services with the delivery of health care. If we aren't addressing the fact that we've got probably 25,000 of our members are homeless, we're never going to be able to provide that person, or the providers with us, like DHS, are never going to be able to provide what that person needs as long as they remained homeless. If they needed drugs that need to be refrigerated, look, they're not going to get it. They're not going to feel comfortable coming in for routine care. I have a provider in our network who runs a federally qualified health center on Skid Row, San Pedro, and when we extended coverage under the Affordable Care Act to many of the people who were homeless, he said, well, they won't come in. And I said, well, why won't they come in? He said, because they don't have anybody to leave the cart with. So they started valet cart parking, and now they come in. So to meet the needs of the social determinants, we have to think of solutions that are aimed at the people and the circumstances they're in if we want to move the needle on health disparities. So our view at LA Care is, let's identify the social determinants, let's figure out ways we can mitigate those and address them. And that informs a lot of our thinking about the future, about how can we integrate social services into the health plan so our care managers can be agents for things like CalFresh, housing subsidies, or any of the other social safety net programs that our population depends on, but we present to them in such a siloed fashion that it would take our members a week of traveling from office to office to office to sign up for the benefits that they're entitled to that would help move the needle on those health disparities. So we would like in the future to be for them that one-stop place where we can organize all those services and deliver it to them.
All right, thanks, John. Kind of two questions here. One is, I know that some folks have asked me, hey, can you guys talk about homelessness? You know, in LA, I think there's 55,000 homeless, something like that. So I know that's a big area. Did you want to maybe just give some thoughts on that? My second question was, you know, along the notion of population health and managed care and how we're moving. I mean, even the federal government's wanting states to, you know, put on Medi-Cal to get more focus on managed care and managing large populations. And on the, at least on my side, John, there's the 2015 waiver. It's a program that allows public hospitals and district hospitals to kind of deviate from Social Security regulations, and so we come up with programs to offset some of that funding. But yeah, any thoughts on homelessness, and what programs specifically are you doing in LA Care to kind of address this growing need that we're seeing?
Well, the last census was 53,000, and we're about to get the results of the current census, which we're led to believe is unfortunately going to be higher. So it's a chronic issue that I think any of us who live in Los Angeles should be embarrassed about. I mean, the homeless are everywhere, and there are certain sections of downtown LA that look like refugee camps, and we do not treat those people well or provide them with access to services. So knowing that many of them are our members, and we know that we have homeless as our members because their address is the Department of Public Health Services. And when we are, unfortunately, we've ended this practice because we got the state to agree to the lunacy of it. We were supposed to send every member of our health plan a directory of our providers once a year, printed directory. We have 15,000, and it has to be in a typeface that's large enough for seniors to read. It's a 5-pound package. We were spending $10 million a year mailing these damn things out to people who we know didn't do anything with them. The worst part was we probably sent about 10,000 to the Department of Public Social Services, where I'm sure they were on the loading dock for about 2 minutes before they were in a dumpster somewhere. So now the state has said, okay, that is pretty stupid. So now we can send them a postcard, and they can throw the postcard in the dumpster. But the postcard merely says, if you want to see the directory, it's online, and we do it that way. So what we're doing about the homelessness situation is very minor, but we think it's an important gesture that we hope will urge others to jump in. So I'm hoping that other health plans would follow suit. Now, your former employer, Kaiser, has, and they have a statewide commitment of $200 million. But our point is, if we are not housing people when they're ambulatory and well, what are we going to do when they get older? Because we'll pick a homeless person who does not get proper care because of their situation, at some point is going to be lying on a sidewalk in distress and will be taken to an emergency room. They will be treated in the emergency room. They will then be admitted. When it comes time to discharge them, nobody wants to send them back to the streets. So if they're older, chances are they're going to wind up in a nursing home. Boom, housing problem solved. But we're paying for it as taxpayers is at the rate of $70,000 or $80,000 a year. Why aren't we thinking of providing a much lower cost alternative for that person while they're ambulatory, and we can do it a lot less money? So one of the things we were able to do with our Brilliant Corners grant is that we did have a homeless guy in the plan. He was living in his car. He had a leg infection, got to the point he had to be taken to the emergency room, admitted. When he was discharged, we had already leased 16 recuperative beds at a private National Foundation facility on Pico and Olympic, or near that area. And while he was recuperating there, we were able to find permanent housing for him. So he left that and went into permanent housing, and it did not go back to the car. Those are the kind of solutions we need if we're going to move the needle on health disparities. So it requires an organization like us, a health plan, who is serving that population to take on a bigger role and responsibility, again, of matching the needs of the member to other social service programs that they're eligible for and making that connection happen.
Yeah, that's fascinating information. I know that as a former employee of Kaiser Permanente, we actually, in a very well-established, well-to-do county further south, where I was, we actually, we were having a leadership meeting one day, and we determined that there were actually, some homeless people that were employed, professional people, and you're thinking, how can somebody that works for Kaiser Permanente, and I'm just I'm sure it happens at many companies, where they had some problem, and so they were basically living out of their car, coming to work every day, and nobody really knew it. So I think we have the obvious homeless, those that have behavioral health issues. They really need. I mean, maybe they're veterans. They really need help. And then there's those that are just struggling. So John, any specific programs that you can maybe talk about, like whole person care or housing for health, or that you might be involved in, or that that are that are in existence that can help with those that are the vulnerable population or the homeless?
Well, if I could start off on your example about people who work for us, I think we have a responsibility for any of us who are employers to pay a living wage. And when I got to LA Care 4 years ago, I asked, what does the lowest paid employee here make? And it was $13.50 an hour. We raised it immediately to 15, and anybody who was at 15, we raised to $15.50. We just this past March have raised the lowest entry-level wage to $16.50 an hour. It's still not great, but it assures that somebody is making full-time over $30,000 a year if they work for us. So I think that's number one. Number two, we are involved in waiver programs like whole person care, and we will be involved in health homes. And these are great programs. But I'll tell you, my view on both of them is it's stuff we should be doing anyway. We don't need a waiver. We don't need a special program to do this. We'll take the additional money that comes with them to put it to work, but we should be doing this anyway every day. Now, the one challenge we have with whole person care is it's a county program that we're a participant in, as is HealthNet, the other plan available to Medi-Cal beneficiaries in this county, and we're all participating in it. And we're all coming with great ideas, and we all want to have a care manager help out patient X. The problem is we're overwhelming patient X with too many care managers, and there's now a phenomenon that I call care manager fatigue, where the patient says, stop calling me, click. I don't want to talk to anybody. And so the biggest challenge we have in whole person care is to get the care managers coordinated so there's one care manager. And the fact that we have multiple care managers, to me, is an indication of how fractured and siloed our delivery system is, not only on the healthcare side, but on the social service side. We don't need multiple care managers. We have to come together, come up with a process that there'll be a lead care manager who has the relationship with the patient. And then we can call in the other care managers or inform them to carry out their end of the deal. But we're losing sight of the fact that the best of healthcare is based on a relationship with the patient and the provider. It is not going to be, no offense to people in the room, it's not going to be an application on your smartwatch that's going to make you healthier. It's going to be the relationship we have with your provider. The care managers are the secret sauce. And within the world of care management, there are care management nurses, and there are community health workers. I love care management nurses, but I adore community health workers, because those are people who have the relationship with the patient and can be the most influential in moving the needle. And let me give you an example. When I was in Boston, I was with an organization called Senior Whole Health, and we took care of dual eligibles. These are people 65 and over or disabled who also live in poverty. So they're the most vulnerable population. And dual eligibles, if you do not know it, there are about 10 million in the United States. And between Medicare, Medicaid, and Part D, we're spending $400 billion a year on those 10 million people. And that's where we need this kind of work. So in that demonstration we were doing in Boston with Senior Health, everyone had a nurse care manager, everyone had a community health worker. And the community health workers were assigned to the patients on the basis of race, ethnicity, or language. And what we found is they could bond with the patient because, number one, we sent them to their homes, and they had a relationship with them. So I met Mrs. Beezer, came into one of our focus groups with her community health worker, and I said, how do you like the health plan? She said, I love it. Teresa, pointing to her community health worker, she said, Teresa here badgered me for over a year to get a primary care doctor, so to shut her up, I finally did. And what did I find? I have this problem and that problem. I'm on meds now, I've never felt better, and I've not been to the hospital since I got the primary care doctor. When she said, Teresa here badgered me for a year and didn't follow it with, so I quit the plan, I knew we were onto it. Because Teresa and she could talk to each other in her preferred language, which was Haitian Creole. And she viewed Teresa as a daughter. And if Teresa could come and say, Mom, you've got to have a primary care doctor, she said, okay. And that's what we need. And information technology is not going to make that happen. We need information technology so Teresa can be more effective in her job, but we can't replace Teresa with IT.
Okay, so don't get disappointed, health IT folks in the room. Okay, we have a job to do. No, because definitely we don't want technology to be leading us, a world full of robots telling us what to do. But what you're saying, John, is that we've got to find a way to add the, to connect with our patients and help them understand really what they probably should have known, but maybe, it's education. So in your perspective, because my next question was just to go into a little bit about the role of government, should we be relying on the government to kind of lead us? Or do we take this, have a grassroots movement? So I know that you're doing some things in the programs, but is there, so before we talk about the government, and then we'll talk about Governor Newsom in the state and some of his bold healthcare initiatives and proposals, is there a silver bullet? Like, let's just say other health systems and other organizations are trying to tackle the problems of health disparity. Is it something that it's mysterious, or is there how can we operationalize kind of what you just shared, that personal touch, and how can we become more coordinated? Is there any thoughts on folks can leave this room here and say, let me do what LA Care is doing, or any thoughts on that, or is the answer there's no silver bullet? We just have to really connect on a personal level.
Well, if I had the silver bullet, I probably would have shot it at somebody and done something by now.
Absolutely.
So no, there is no particular silver bullet, but I think that we have to collectively recognize that our system of healthcare and social service is very fractured, it's very siloed, and what can we do to break down those silos and begin to integrate them in a fashion? So to the extent that our view at LA Care is that we as a health plan, which have responsibility for paying for all these services, and we want to be responsible stewards of public money, we should be looking at ways to do that integration for the benefit of the member. And if we can get the member to participate, great. But in many cases, because of the social determinants, they're not going to be able to. They may have a language barrier, an education barrier, a transportation barrier, a housing barrier, a food insecurity barrier, and we should be helping them address those things. And frankly, I don't see any organization or entity that is better suited to do that than health plans, because we cover so many services that people are related, that people depend on, and we have to collect so much information about those people. I think it's something we should try on a bigger scale.
Okay, so I know John and I had a couple of conversations before this event, and one of the things that you were sharing with me, John, just about, the financial industry, how they globally, kind of became very interoperable and highly communicative, and so you can take a credit card now and go, and although I just came back from China and they don't accept credit cards, so you have to use your smartphone, but or WeChat, but any thoughts on should we rely on the government to kind of move us forward in this, or is there a way for us, maybe the health plans getting together, how can we move this forward maybe better than we're doing right now? So any thoughts on that?
Sure. I think now we view ourselves, LA Care Health Plan, as a public entity, but we're not the government. We just operate in an open and transparent way. Look, if we look at the two biggest health programs that the government is involved in, Medicare and Medicaid, which have been with us for 54 years, look what's happened to them over the 54 years. Medicare, the day they went into business, they did not hire a whole bunch of people in a warehouse somewhere in suburban Maryland or Virginia to process Medicare claims. They contracted it out to intermediaries, a la Blue Cross plans. So managing the Medicare line of business for the government, Blue Cross has made a lot of money in fees doing that over the years, the various intermediaries. But the more important thing is 35% of the Medicare beneficiaries are now in private health plans, voluntarily. They signed up for Medicare Advantage plans. And Medicare Advantage plans are very appealing to seniors because they throw in extra benefits. But they're managing the care, so they can take the revenue they get from the feds, which is a risk-adjusted dollar amount based on that particular person's profile. And they can provide all the services and throw in the extra benefits because they are adding this level of managed care, which is valuable. If you look at Medicaid, we now have 80% of the Medicaid beneficiaries in the United States are in private health plans because the states threw up their hands saying we cannot manage the utilization in a fee-for-service Medicaid program because when you get a Medicaid card, it's the ultimate credit card. There's no limit. The only problem is you got to find somebody to take it. And so the states over the years have migrated, like California did, to managed care, and now 80% of folks are in it. So I think the question really should be, how can government partner with the private sector to deliver these services in a better way? And one question I would pose to people, particularly those of you that are single-payer advocates, where's the competition going to come from in a single-payer system? I have a competitor, it's HealthNet, and I look over my shoulder at what they're doing and say, are they doing something more for their members than I'm doing for ours? So I think that competition drives innovation. Likewise, being in Covered California as one of 6 plans, I'm looking over my shoulder at the other 5, and I know damn well they're worrying about who the hell is LA Care? Where did they come from that they're now the largest carrier? So I think we can be partners with government because government can harness resources in a way the rest of us can't.
Yeah, and actually, as you were saying that, it really makes sense. The public-private partnership is really, we need the government. They can set guidelines and boundaries, but really the innovation and a lot of the things that happen at the front lines, is going to come from the private industry. Venture capitalists. So I know that we have a number of vendors here today that are really looking for opportunities. Like, hey, where is an opportunity for my software company or my organization to really make an impact? And was it the Gordon Gekko in Wall Street that said, those of you guys remember that movie, follow the money? So it's important to know kind of where the money is. So that's kind of why we started out our conversation this morning, just a little bit about from a financial perspective. So you mentioned the single payer. I know that's a lot of people are talking about that. But really, I had two questions. One is, Governor Newsom is new in office, and he's got a number of different initiatives like expanded coverage and greater coverage for immigrants, single payer plan, even discussions about using general funds for health care, and upping the age for Medi-Cal to 26, I think. So just thoughts on some of those initiatives. And then I did want you to comment also on the fact that the tax penalty for the ACA at the federal level has been repealed. So that's impacting the number of people that are, that are actually signing up and getting, health care coverage. So from what I understand, we're okay with the ACA not going away until 2020 or after or something. But thoughts on some of the initiatives from Governor Newsom as it relates to health disparities, and then maybe a comment about the what's going on with the ACA and how you feel like where it's currently at is impacting us.
You managed to crowd about 8 questions into that. That's pretty cool.
If you get lost, I'll help you out.
Well, Governor Newsom came, first day he announced 4 major initiatives that affect all of us. The first is he is proposing that the state of California impose its own insurance mandate, that you have insurance or pay a penalty that would match the one the federal government had for the ACA that was taken away when they adopted a new budget in December of 2017. And we think that's a good thing, and it would be the same level and the same amount. And before I go on to the other things, let me comment. As we went into 2019, that was the first year the tax penalty under the ACA was not in effect. My guess is maybe 20% of the population understood that and gave a hoot about it. But when we went out with our program this year, we grew in covered California. We added another 15,000 lives or so. So people are still buying it, regardless of the mandate. The mandate was really there to make sure that lower risk, younger people joined the pool to give it some more actuarial balance. I think from what we've looked at the demographics of our enrollment, our largest cohort of people is between 50 and 59. This tells me there are people out there who don't have access to group insurance, either because of early retirement or disability, but have income that's high enough that they can come into the exchange and buy it there, and they're buying it because they need it. We do encourage the mandate because we do think we want to encourage younger people not only to be in the pool to help balance it, but not to be such, and I have millennial children, to kind of say this, but not to be so arrogant that you think you're invincible. Someday you're going to need health care. Get used to having a plastic card in your wallet and use it. So we're in favor of that. So we think that's a good deal. We can't tell from our enrollment in this past enrollment period if the loss of the mandate made any difference because we grew. We're also operating in a state that's got a gung-ho economy, low unemployment, high employment, so the demand for the marketplace is not as great as it would have been 10 years ago. So we don't know the answer to your question yet. The second thing the governor proposed was that for people who did go into covered California, he would increase at the state's expense the amount of subsidy or advanced payment tax credits that people get. Right now, if you come into covered California, you earn more than 138% of the federal poverty level, because if you're below that, you're in Medi-Cal. And it's up to 400%, you get some level of subsidy through these advanced payment tax credits. And of course, it diminishes as your income goes up. But 90% of the people enrolled in our plan in covered California get a subsidy. And for somebody who's at 139% of the federal poverty level, they're probably paying something like $10 a month for their coverage. Anyway, he is proposing to expand the subsidy up to 600% of the federal poverty level, all at the state's expense, using the tax revenue generated by the mandate to fund that. All good stuff. The next thing that he proposed was expanding coverage for undocumented citizens. Right now, California pays 100% of the cost of undocumented children who can enroll in Medi-Cal, and that started in 2016. And now it goes up to age 19. The governor is proposing it to extend it to 26. Good thing, we think, as well. The fourth thing he announced was that he wanted to tackle prescription drug prices and wants the state to become a purchaser of drugs on behalf of the 13.5 million people in the state who are on Medi-Cal. And his thesis is they're a bigger purchaser, they can drive down the price. We think that's a great goal. We're a little concerned about how the execution can go, because drug pricing is the most obtuse thing you can ever look at. You'll hear about rebates, and it's just a discount gimmick. But the real problem is the list prices, and if we don't address list pricing, no amount of aggregating purchasing power is going to get you much of a bargain. So we're applauding the governor. We'd like to be partners, however, with the state on planning this, because it would really take prescription drugs out of the benefit package we administer for our Medi-Cal members and have the state set up a bureaucracy that would run it. And no disparagement to Governor Newsom, but can you imagine the state of California setting up a program to administer prescription drugs to 13.5 million people, have a state formulary, and then have a call center that will handle with all the calls from doctors saying, I want my patient to get the brand name, not the generic, or I want a drug that's not even on the formulary. We're responsible today for doing that, and we get 1,100 calls a day from people who need a formulary adjustment, and we're required to turn that around in 24 hours. So I think it's not impolite to ask the governor, can you do that for 13.5 million people? And all I have to say is TMV.
Okay, Houston, we have a problem. Okay, so that sounds like that would be a challenging endeavor. I'm not sure what's in the works for those that are behind that.
Well, it's a laudable goal. It's just, let's not go for a goal that's a nice slogan or, 30-minute campaign announcement that's going to create havoc and disruption in how we distribute a very important item, prescription drugs, to people.
Right. Oh, and one other thing that I read where the governor has a task force to address the healthcare worker shortage, and we know that if there's people that need care, then we don't have enough healthcare workers. So any thoughts on if that is going to really impact us, particularly with health disparities, or is that just something we need to do and we'll have to find a way to manage without the appropriate numbers of healthcare workers? And of course, a lot of us in here are emerging professionals or looking to get into healthcare, or maybe saying, where is the next 5-10 years where my role could be really valuable? I really want to make an impact. So, thoughts?
Sure. Well, I think the biggest issue that is of concern to us is that we need more doctors, because we have an aging workforce of medical professionals like me who are boomers who are saying, well, I'm done, and retiring. And a lot of those are in communities where the younger doctors are not going. So we looked here in Los Angeles at the MLK Hospital, which is based in South LA, serves a very poor community, and they've identified that today, we have a shortage of 600 primary care doctors just in the catchment area of that hospital, and the specialist number is higher. So to tackle that part, I think the thing that strikes me the most about how we approach this in the United States is that we are the only first world country that does not support the medical education of our future doctors. It's entirely up to the doctors. Hey, you got into medical school, good luck raising that 350 grand. It's gonna cost you. Other countries, they either provide it and they monitor how many people get in, but it's either paid for, or in Canada, they pay about 3/4 of the education. That allows those doctors who don't have that burden of debt to make choices like, I will do primary care, as opposed to saying, well, I'm loaded with debt, I'll never survive as a pediatrician or an internist, I'm gonna have to become a plastic surgeon or a colorectal surgeon or something like that. And we have plenty of those, well, they'd argue with me, but we have plenty of those guys. We need more of the primary care. So first of all, we've got to, as a country, say, are we gonna support medical education and get the monkey off the back of the doctors of medical school debt? At LA Care, we have to maintain reserves. It's part of our insurance requirements. That money sits there, and it's there, and I'll tell you what we use it for. It's about $700 million right now. Sometimes the state doesn't send the check when they should at the beginning of the month, and they'll call up and say, hey, we're a little short, we'll send you your check next month. So those reserves allow us to continue to pay the providers and pay the hospitals and keep the wheels rolling and the works greased to keep things going. But I went to our board and I said, we need to help out on this workforce development thing. So we took 5% of our reserves, about $31 million, and we said we're going to put this towards workforce development. And we are offering grants to clinics or private practices that will bring new primary care doctors to Los Angeles County to work in the safety net. The grant to the institution is worth $125,000. They can use it any way they want to be more competitive. Because what happens in LA County is when new doctors are available and they come in, your old employer Kaiser sucks up most of them because they offer higher salaries and benefits than the safety net clinics and practices can do. So we want that grant to help them compete. If the doctor they hire, who is new to the county, they can't hire the guy who's already here across the street, is new to the county and that doctor has medical school debt and agrees to stay 3 years, we will retire $180,000 of the debt. So the package is worth $305,000. And I'm pleased to report that the first year class of 8, I feel like I'm a parent with 8 kids in college at the same time. They all made it out of the first year, so we're happy about that. But more importantly, we told the colleges, you do this all the time. You can probably spot the student walking in the door that you can tell will come back here and practice if they have the right incentives. So in the first class of 8, 5 were women, 5 were Latino, 2 were African American, and 1 was Asian. They were all of color, and we need that diversity in our workforce to match the diversity of the patient population. In July, we will be announcing the next class of 8, and I'm going back to the board for 5 years and asking for a 5% set aside each year for 5 years, which should give us a fund of over $150 million, which could fund 40 scholarships and provide enough grant funds to bring 400 new primary care doctors into the safety net. And again, I hope we're setting an example for other health plans to do the same thing.